So good morning again, and would like to continue with the second part of this presentation on clinical applications of the affect balance principle based on affect regulation, at this time talking about considerations of substance abuse and addictions. And I don't have to repeat these things, I talked about it before, so I move on and go to the first case here. Greg is in first grade. Both the school and his mother sees him as an easily agitated, aggressive boy who may also have reading disability. When angry, he either goes into destructive and assaultive rages or shuts down completely. At age 5, he was diagnosed with ADHD, bipolar disorder, epilepsy, and traits of sociopathy, which of course probably corresponds to conduct disorder, but no medication was prescribed. Recently, he held a knife aimed at her mother's face while she was asleep. Then he placed thumbtacks on the floor, admittedly to make her cry. In other words, he was hoping the mother would step into those thumbtacks. He often punches his 8-year-old sister in the face, yet mother infantilizes him by bathing him and tying his shoes. Both parents are alcoholics and cocaine addicts. When he was between 2 and 4, mother was in jail, and he lived with his father and sister. Just before his mother got out of jail, the father was jailed. In the intervening 2-3 months, he was with his grandparents. In my office, he was first anxiously restless, but in good mood as he calmly worked with me on paper-pencil tasks, showing interest and competence in performing the tasks, but his mother repeatedly interrupted, "Sit and behave respectfully." When asked about his behavioral problems, he said he didn't like the school because people were not nice to me, claiming that he was bullied in school and mistreated by the neighbors. His mother retorted, "You are lying." This made him suddenly very angry. He pointed his finger at his mother. "You never believe me, but others." Then he shut down with marked psychomotor retardation, very sad facial expression, and started to cry. I was able to slowly re-engage him by saying I wanted to understand his sad and angry feelings to be able to help him. By now he must have sensed my genuine interest in him and that I was on his side, i.e., that I believed him. This positive affective experience tilted his affect balance toward the positive, and he was able to leave his cocoon and look at me. It turned out that he has been very sad and angry ever since his mother yanked him out of his recent happy family life with the grandparents and cousins. This reignited his traumas of abandonments by the parents and the multiple placements. Now that he finally had a stable home and a positive affect balance with his grandparents and cousins, his mother again robbed him of the persons and circumstances that were good affect regulators for him. As we reviewed his history, he angrily called his father a not responsible parent, and wasn't afraid to tell Mother, in my presence, that he was still angry at her too. Clearly, he did not respect and trust either of his parents, even though his mother has been abstinent from abstinence of alcohol and drugs for 3 years. But was there anything he enjoyed and had fun with now? I asked. Big sister, he said. Then he told to his mother, encouraged by my support, that he very much would like to live with his big sister more than with his mother. But most of all, he would like to return to live with his cousins. Mother secured for him the big sister, as no big brother was available, to serve as an emotional companion. You know about this big sister, big brother system. So that's what we are talking about. My interpretation is that in Greg's presence, I told his mother that Greg's behavioral problems stem from the intense anger, sadness, and lack of trust rooted in his past traumatic experiences caused by parental abandonment and rejection. I said that the task was not to focus on and punish him for his behavior, but to show that his feelings are being understood and his suffering is respected. Thus the task is to build a trusting and respecting relationship between her and him. My conclusion is, Greg's attachment to his primary caregiver was shallow, insecure, and ambivalent, and he had little use for it. Mother has been an unreliable, poor affect regulator who added insult to injury by punitive and non-empathic attitudes that have been harmful to Greg's affect balance and self-esteem. Yet she was able to accept the insight I offered and showed willingness to reflect and to try to empathize with Greg. She was receptive and contrite and owned up to her failures. She was going to discuss this with the school too, namely these insights that I was telling her. This had an immediate salutary effect on Greg's mood, as he seemed to realize that I understood him well and that his mother was willing to listen to me. He left in a positive affect balance with a hopeful outlook. It was possible to accomplish this in a single session. I prescribed no medication for him. Addendum to this case. Addiction is a maladaptive attachment which is also based on the affect balance principle. The tragic aspect of Greg's case is that his parents' alcohol and drug addiction still hurts him. Father is in jail, again, and mother is still affected by it to the detriment of her mothering and of Greg's personal development. First, as it is typical for addicts, she was primarily attached to her substances, i.e. those were more important than anybody else, including her child, that led to her abandonment of Greg. Now that she is abstinent and just out of jail, she again subordinates Greg's interest to hers. She has been anxious about relapse due to her prior connection in the area where she lived, or where they lived, grandparents and so on. So she wanted to move away so that she wouldn't relapse, which was a healthy choice in affect regulation for her. However, she also has to cope with her guilt about what she had done to Greg. So she drags him along, disregarding his interests of staying in a happy family environment, as if she wanted to use Greg, i.e. her mothering of him, as an affect regulator to assuage her guilt and to feel better about herself. My addiction theory is that addictions are maladaptive and pathologic attachment because the objectively harmful substances and activities and fantasies to which addictions develop are subjectively experienced as effective and reliable affect regulators and may be conceptualized as pathological transitional objects or phenomena. Distorted or unstable self-image and identity may render individuals vulnerable to addictions, or addictions may lead to distorted or unstable self-image and identity. Interferences with flexible, healthy affect regulation, or the loss of capacity thereof, in any of the domains of the affective system, somatic, behavioral, or psychological, may lead to rigid, maladaptive choices of affect regulation. My addiction theory in context. Vernon Johnson, in 1986, called chemical dependence as a disease combined with an emotional syndrome. Of course, the American Medical Association in 1956 declared alcoholism as a disease. But anyway, this was about chemical dependence as a disease combined with an emotional syndrome. He also called it a feeling disease. The nomenclature is confusing, yes, yet the content is insightful. Chemical dependence equals emotional dependence. Chemical dependence is a biological concept and always involves substances, while emotional dependence is a psychological concept that implies attachment and may involve persons, objects, activities, and fantasies. Vernon Johnson described the phases of developing addiction as follows. First, the person experiences, learns about mood swings. I say, first, the person recognizes that the chemical brings about a positive affect shift. Johnson says, the next phase of development of addiction is seeks the mood swings, not just experiences, he seeks out the mood swing, starts a trusting relationship with the substance. I say he looks for a reliable and effective affect regulator. The third phase is when the addiction is developed, harmful dependency has developed. I would say pathologic attachment has developed. Of course, another later aspect of the addiction is that when the person is addicted, many times he has to continue using because otherwise he would experience the withdrawal symptoms. And so I would say that this is masking chronic depression, which would lead to anger and distorted thoughts and denial and delusion. So nowadays the delusion is part of the definition or the criterion of addiction. Let's look at a teenage girl. Carol, 14, a Caucasian teenager, has been in a therapeutic foster home for the past 6 months and is now finally motivated to change her life. In recent years, she has been suffering from depression and with suicidality and anger outbursts and engaged in polysubstance abuse and sexual promiscuity, and was often suspended and truant from school. Yet, she has always been a good student. "I have been lied to in my whole life," she said. "I have not felt important to anybody. I don't trust people." Carol was raised by an alcoholic mother and her husband, who she believed was her father, and that through him she had 5 older siblings who were grown-ups already. When she was 10, her father left, and suddenly she had no family and no home. First, she lived in a shelter with her mother. Then she was placed to her maternal grandmother and uncle. Then she learned from her mother that the man she grew up with was her stepfather, and that she had no biological siblings. My formulation is that her alcoholic mother was experienced by her as an unreliable affect regulator, resulting in an insecure, ambivalent attachment and an insecure sense of self. She suffered immense losses by the abandonment by all of her parents and by the disintegration of her family, which were traumatic experiences. When I say all of her parents, I'm talking about 3 parents, the biological father and mother and the stepfather. In the state of an overwhelming negative affect balance, she couldn't count on anybody she knew for affect regulation. She had to rely on herself for affect regulation, but her overwhelming sadness, anger and self-doubt compromised her judgment and impulse control, and she ended up in a major depression. The promiscuous sex and drug use gave her a false sense of being accepted and wanted. Her early puberty at 9 made her vulnerable to early sexual activities which became intertwined with the indiscriminate drug use. In middle school, severe facial acne made her target of bullying, which led to her aversion of school. Her good academic potentials could have served as a reliable affect regulator and booster of her self-esteem, but the bullying robbed her of that. Her increasing distress, anger and hopelessness deepened her negative affect balance. She realized more on maladaptive and harmful ways of affect and self-esteem regulation, and truancy followed. My conclusion was that she has not become addicted or attached to any of the substances or activities. Drug use, promiscuous sexual activity, truancy are not priorities of her treatment because they will fall by the wayside in treatment. Except what makes them part of the treatment is to acknowledge except for the acknowledgement of and empathy with the suffering that the maladaptive means of coping caused to her. So that acknowledgement and empathy would be part of the treatment, but not focusing on the behaviors. Her motivation to change her life is key to setting specific goals for treatment, and her efforts need be aided by placement in a therapeutic living environment. By learning about her abilities for healthy means of affect regulation, she will be able to develop and maintain a positive affect balance and self-esteem. For a while, she needs fluoxetine and trazodone medications for the treatment of her depression and insomnia. Here is another teenager, Tyler, who is 16 and was referred for a substance abuse assessment because his mother found drug paraphernalia in his room. His grades have been declining and he lost interest in previous enjoyable activities such as playing lacrosse. He smoked marijuana 5 or 6 times a week, he said, to be able to cope. These were her words. He smoked the marijuana to be able to cope with boredom and with conflicts between him, his mother, and his mother's fiancé. Tyler was a biracial child, born to his teenage white mother, without support from his African-American father, with whom he had no contact at all in the past several years. He was rejected and denied the opportunity to know and clarify his feelings about his father, especially now when he had to work out his own sense of identity. My formulation is that his mother was insensitive to the emotional effect of the rejection by his father. He has likely felt that his mother had not valued him either. This weakened both his attachment to her and his sense of self-worth, identity, and confidence. Then, his mother became involved with a white man and had a white man and had a white child by him. In his state of increasingly negative affect balance that was partly caused by his mother, he could not turn to her as an affect regulator because he experienced her as unreliable and not trustworthy. His attachment to the mother was shattered. As a biracial child in a Caucasian family, he likely felt as a devalued alien. This made him feel angry, anxious, depressed, the manifestations of which could have caused the conflicts within the family. There was nobody to whom he could have turned to help regulate his negative affects. Playing lacrosse did not help either, so he dropped it and chose marijuana for affect regulation. The treatment would consist of conjoint therapy with his mother to work on his ruptured attachment to her. Family therapy with his mother and the mother's fiancé to clarify the relationship problems and to find appropriate solution to them. Individual therapy to help Tyler to find pro-social activities as his own constructive affect regulators, whereby self-worth, identity, and confidence would improve, and he could replace his maladaptive attempt at coping with his depression, which he called boredom. Non-using friends to occupy his leisure time would be also part of the therapeutic efforts. The outcome was that Tyler and his mother have learned positive affective communication skills and improved the relationship. Tyler has reduced his marijuana use to about 1 or twice a month instead of 5-6 times a week. He has more energy and desire to engage in activities. He returned to play lacrosse in his school team. My conclusion is that Tyler re-established a secure attachment with his mother. Mother now may serve as healthy and reliable affect regulator. Tyler does not feel any longer as a devalued alien in his family and is able to develop a positive self-esteem and increasing self-confidence. He is now able to resolve and rectify his other relationship in the family and beyond his family with confidence without the need for marijuana. Yet another teenager, Tom, who is 15, who was recently kicked out of high school for assault on a staff and locked up in the detention. This made him so severely depressed and guilty that he wanted to commit suicide. In my office, he was very remorseful and repentant. He grew up in an intact African-American family as the youngest, only male child. His father is an alcoholic and drug addict, and mother has been the breadwinner and disciplinarian. In his anger, father threatens him to kill him, while mother threatens him abandonment. I have been in trouble all my life, he said. My father told me about sex and condoms when I was small. I had the worst behavior and repeated the first grade, but partly due to learning disabilities. In middle school, he attended an alternative school, which was, of course, for kids with behavioral problems. At 12, he started to have sex with girls, and by 13, he was a daily user of nicotine and cannabis and used alcohol on weekends. When his great-uncle died of drug overdose, Tom became very sad and angry. That was a big loss, he said, because Tom was very close to him. Now he blames himself and accepts responsibility for all the behavior problems of his life, while explicitly excuses his parents from any responsibility. Now he wants to change to have a happier adulthood and would like to go to college. But right now he just desperately wanted to go home to his mother and to see his sister who was back from college on a visit. My formulation was that Tom has had an emotionally traumatic childhood. His father repeatedly has made him experience pain, fear, anger, and a sense of danger and insecurity. He has had a strong, albeit not secure enough attachment to his mother to be able to turn to her for the relief from a negative affect balance, but he has been aware also that he has not lived up to her expectations. So he could trust and he felt that he could rely on mother, but he knew that he was not good enough for her because of his behaviors. Thus, he had to change before mother would be available to him as a fully reliable affect regulator. Autonomous affect regulation could theoretically have relied on cognitive and athletic prowess, but his cognitive limitations and failures in school prevented him from using those means. He has tried to cope with his frequently negative affect balance by identifying with his father through sex and drugs, and those maladaptive means of affect regulation gave him a false sense of mastery and control. His first ever separation from his mother was now in the detention home. That was the first time that he was ever separated from his mother. He became overwhelmed by the fear of losing her because she was still the most reliable affect regulator available to him to improve his miserable negative affect state, or because she might indeed abandon him as she had occasionally threatened. So he was very frightened that now is the time that mother might really abandon him. He wanted to identify with his sister to be acceptable to mother, as she has been. For example, by saying that he wanted to go to college because the sister was going to college, so he wanted to go to college so that would please mother. This promised to be the best way to reach a positive affect balance. During his traumatic childhood, The most reliable and unconditional affect regulator apparently was his paternal uncle, who was probably the substitute of the wished-for father. His loss severely perturbed Tom's affect balance and made him rely even more on his ineffective maladaptive affect regulation by using drugs and pretending he could not be messed with and by the school authorities, and of course it led to assaulting one of them. The conclusion is that polysubstance abuse and precocious sexual activities have been maladaptive but autonomous affect regulators. He will not need those once he is committed to work toward acceptance by his mother, and thereby securing her availability for healthy affect regulation, and in the process he will be able to increase his self-esteem. Let me turn to an adult case. This is the so-called alcoholic women. Mrs. A became a heavy drinker in her late 40s. She tried to hide it, drank when alone at home, but some friends happened to find her drunk. Her husband was on the road for days at a time. He also concluded that she needed rehabilitation. When admitted to a residential program to start on the road toward abstinence, she realized she didn't belong there, and she left angrily after 4 days. She realized, however, that she needed help and agreed to see me as the psychiatrist addictionist. The initial interview established the dynamics of her drinking. She was not addicted to alcohol, just wanted to get out of her helplessly depressed mood. She felt abandoned by her husband and thus devalued. She just wanted to numb her psychic pain by alcohol. She did not feel devalued when her children left home, since her husband stayed with her and confirmed her accomplishments and worth as a mother and a wife. However, when her husband started to spend more time away from home, she felt that his job had become more important for him than she was. Her feeble attempts at expressing her feelings were insufficient to alert him to them. She blamed herself for her emotional predicament, yet it became clear to her too that she would not need another drink if her husband would have understood and attended to her emotional needs. Once we clarified the dynamics, she agreed to bring along her husband for a conjoint session. Indeed, he wanted to understand what had happened to his wife that made her become an alcoholic. My formulation was that the interpretation presupposes that after her children left home, she lost the affect regulatory function of active mothering, both in terms of her accomplishments and her sense of worth and importance, i.e. in terms of her self-esteem. However, at that time she must have experienced sufficient compensatory affect regulation by her husband being at her side, confirming the importance of her mothering and thereby of herself. Later, she lost much of what her husband meant for her as an affect regulator when he started to spend more time away from home, and her affect balance became negative by the increasing sadness, distress, and anger. She was unable to find constructive substitute affect regulator by looking for some interests or activities including narcissistic ones, that could have generated positive affects and thereby moved her toward positive affect balance. The maladaptive choice of alcohol served as affect regulator only to the extent that it ameliorated temporarily the psychic pain caused by the negative affects. Intervention and outcome. My interpretation of Mrs. A's emotional state was completely understandable and a relief for her husband. The insight helped him to do what she needed, offering his emotional availability to her. Both left the session empowered and satisfied, and neither she nor they needed to see me anymore. My conclusion was that she was rescued from continuing on a dead end and deadly course. By the insight, she had the tools for healthy affect regulation in the future, and all this was accomplished in 3 sessions. Conceptual considerations about addiction. Brain diseases is the new definition of substance abuse and addictions by the American Society of Addiction Medicine, based on ongoing brain research. But in the opinion of others, including me, that is a false oversimplification. Dopamine release increases the activity in the reward enforcement pathways of the brain, but this is part of all rewarding activities of non-addictive persons as well, i.e. it is not specific to drug-induced high. Substance abuse and drug addictions are not simply about the pharmacological effects of the brain. They enter the person's affect economy and have to be understood in the context of the life, choices, and needs of the whole person. The affect balance principle is about the workings of the affect economy of the whole person, who is developing, changing, and coping. The neurochemical processes of the brain represent the somatic domain of the affective system, through which substance abuse and addiction may become part of the affective economy of the whole person, because there are dynamic interrelationships among the somatic, behavioral, and psychological domains of the affective system. Defining substance abuse and addiction as brain diseases is a regressive step toward reductionism that has plagued medicine for the last 50 years. The genetic biological view of diseases led to losing sight of the person who is ill. The concept of the affective system, with its somatic, behavioral, and psychological domains, is consistent with the holistic approach to healing of the ill person. Dysfunctional affect regulation in infancy and early childhood that may come about by early traumatic experiences as well leads to disorders of attachment, object relationship pathologies, and to disorders of sense of self, identity, self-esteem, narcissistic pathologies, and bodes ill for substance abuse in adolescence. So dysfunctional affect regulation in infancy and early childhood bodes ill for substance abuse in adolescence. Secure attachment, on the other hand, stable object relationship, and positive self-esteem, healthy narcissism, in early personal development provide probably the most effective prevention of adolescent substance abuse, because they imply effective and healthy affect regulation and affect balance. Thank you very much for your attention.